So, hello. We must rethink hospitals as entrepreneurs, which is what Guy Valencien said this morning in the Gazette. Now, he teaches us that being enterprising comes from Latin, interprendere, seizing with your hands. Now, can we seize with our hands this hospital, this healthcare system? What I suggest is that to begin with, let's try and diagnose the situation according to you. You know, what should the healthcare system be in your country, in France or in Denmark? We'll start perhaps with Anne JASTRUP, who's in charge of a very big hospital in Denmark.
And what about the freedom of entrepreneurship?
First of all, let me thank you for inviting me to this very inspiring conference and for your interest in the Danish healthcare system. When that's said, I think that Danish hospitals generally have a huge amount of managerial autonomy, but at the same time we are, as I guess you are, regulated by comprehensive policies, strategies and professional guidelines. So it is necessary for local freedom and local management, and therefore also for local entrepreneurship. I think that policies and strategies are determined not to go beyond the why. They must ask the big why, while the what and the how must be in the hospital management. It must be the hospital management who decide what to do and how to do it, and the political who says, why should we do that? So I think that's that kind of freedom we have. But from a more intern perspective, if you talk about innovation and entrepreneurship, I think that the professional innovating force at hospitals has a very strong intrinsic drive, and it's stimulated by research and professional entrepreneurship. However, if we're to succeed with sustainable healthcare, I think we have to be a lot more focused upon organizational innovation. And I think this is where it becomes hard. Because when you talk about organizational innovation or organizational entrepreneurship, you confront often habits, long-term cultures, and possibly also the loss of identity and prestige for individual departments or individual professions such as doctors and nurses. So, and among that, I think the organizations, doctors and nurses organizations, sometimes are a little bit conservative in wanting to bring development into the hospital care solutions. So when you talk about the professional innovative force, I think it has, it works good, it works well, but the organizational innovation and entrepreneurship could be better in our country at least.
Merci.
Thank you. Aurélien Rousseau, you're in charge of the Paris Regional Health Agency in the Paris area. Do you have to confront the same obstacles? We've heard that the obstacles often come from the personnel itself versus the innovation. Do you have the same experience? Well, first of all, I'd like to say that the hospital is a place for patient safety above all. And it's also a place where we invest a huge amount of public money. So it's normal that there's an attempt to be careful and to control risks. Risk control is at the heart of our activity. And I think now we are at a moment where this risk control, we should tell ourselves that it's not necessarily contradictory with innovation. That's the first thing. Secondly, and Thomas Meunier might like to interrupt me here or contradict me, but the conflict that we've had in the French emergency wards in the French hospitals is very topical, and it's based on the idea of service. And despite the organization and despite all of the rules, no emergency ward resembles another. So yes, there are spaces for innovation that are sometimes exploited even and used by the professionals in the emergency wards. But it's certain that we must change. We are really stifling under certain constraints. we shouldn't abandon innovation. Yes, there are many constraints, such as, for example, when I visit the hospitals, people tell me that they have to fill out these reporting tables. Nobody has any idea where these figures are going to go. And there isn't even an information system to process the data. We also have to encourage global contracts between the authorities and the establishments. We need to set the objectives for the establishments and then let them organize themselves based on their own resources. In Île-de-France, around Paris, we've organized this. We have a pact for the renewal of the emergency ward. We call it zero stretchers contract. So then it's up to the doctors who will organize themselves with all of the professionals, the nurses and the doctors, to make sure that no one is left on a stretcher. But I think we need to assume heterogeneity as long as the principle of equality is respected. The second point, as someone just said, I believe that we need to learn from other expertise. We have the technical expertise of the directors, of the heads of departments. We have the carers and the paramedical staff and the doctors and nurses. And obviously, we have the patient experience. In Île-de-France, we launched a call for innovators recently, addressed to all of the staff. And I said, propose things to us that you haven't seen to make improvements. There are many digital solutions that were proposed to me. An ambulance driver proposed a solution to me, and then I received a request for a sanction by the department head because it wasn't validated by the department head. So that's a question of culture. So it came all the way up to me. So obviously, this was a big waste of time. And this conference in Chamonix is useful for this purpose. There's not, on the one hand, the administration that blocks everything, and on the other side, people who would be reined in terms of their innovation. No, sometimes we're very comfortably installed in our roles. And I think we need to make progress collectively. We need to accept what is our core profession. We need to test. We need to have some trial and error in our reorganization and in our innovation. This is what we're asking private doctors to do in these territorial healthcare centers, but we need to do it as well in the hospital. That's Article 51. The idea in Article 51 is to say we don't necessarily standardize through tarification. And the last point that's important for me is I believe that what we're hearing from the field seems very ordinary, but I'm still going to say it, which is that innovating, letting your staff innovate, is not necessarily intuitive. It's a real skill, and it's a very tough skill, and it's called management. And management must irrigate much more widely in the public hospital in particular, and it must irrigate the administration and the doctors, because it's not a soft skill. It's not an intuition. Management is something that needs to be structured, and we see this with everyone. If you do a lot of visits and dialogue, this is something that plays an important role, and I think this means we need to come out of our role-playing. Each person needs to take their own responsibility. If we remain complacent with our certainties, none of us will change. Thank you, Aurélien Rousseau. This is a perfect transition to give the floor to Marc, because he's a former student of a very prestigious healthcare management school, and now he's the Director General of the hospital in Toulouse. Do you feel like a CEO or a company manager? Guy Valencien was asking us whether the hospital is a company. Is that a taboo, or is your big university hospital in Toulouse like a company? Well, I think it's both. Our hospital in Toulouse, just like any public hospital, and in particular university hospitals, of course, carry out their missions in the context of public service rules that you've evoked, which are intended to guarantee a coherence in a system that we know. It's a system of national solidarity, which is based on a few principles. The principle of neutrality when treating the patients, but also This is illustrated in our neutrality rules for public tenders and the principle of equality. And one principle that we haven't touched upon much this morning, which is both constitutional and also important to avoid making mistakes, but it's also an obstacle, which is what we call the precautionary principle. And the question is to determine whether in the context of these public service rules that we are working in, are these rules an obstacle to the freedom of initiative? I would like to now refer to this paradox. We have these very complex rules. We have rules that we might want to complain about, and many people in the hospital complain about these rules. But at the same time, the public hospital is an absolutely unbelievable source of projects, initiatives, intelligence, sharing, and data. And what we can observe is that when we reach a certain level of internal consensus, externally and internally with public and private partners, you can achieve miracles. And you succeed in laying down the foundations for cooperation, which are complex project management, for example, which allow us to go very far in how we use a large amount of public money. For example, there's a consortium project in Toulouse where we have huge quantities of research projects everywhere. We know we have over 2,000 projects at the same time. We're carrying out a consortium project right now that's extremely relevant and very important around a cohort of over 1,000 patients, unique in the world in the area of aging. So this means that we have rules. We must apply the rules. Yes, they exist because they guarantee a certain number of things, but at the same time, we are able to manage projects, attract funds, and attract skills. So the question that I want to ask here, maybe I'm sending back your original question, rather than asking about the freedom of entrepreneurship, which leads to the question that you asked: is the hospital a company? We could debate this for hours. We could get very strong and say yes, it's a company. No, it's not a company. But I would pose the question. I would raise this question differently. I think the question is whether or not today we can align the creation of scientific value, the creation of medical value, with the creation of economic value. And I believe that everything is done today through the PACT law, the new law, and the new regulatory initiatives in France, and the change in mindset that we can come back to. Everything is being done so that this alignment becomes possible. Thank you, Marc. Yes, health is not just at the hospital. Didier DELETTE is not just a GP. He is a doctor, but he's also the founder of a healthcare center that they call Maison de Santé in France. And I would like you to give us your diagnosis, because setting up one of these healthcare centers, it is a real enterprise. It's a company. It's a business. And I'm sure you encountered a certain number of obstacles to innovation with your project. Can you tell us more? Yes, that's why I'm here. I'd love to. Yes, I was lucky enough to initiate a pluri-professional, pluridisciplinary healthcare center 12 years ago. It was a beginner's initiative at the time. I live in a rural area in the north of France, in the Pas-de-Calais, half an hour away from the hospital, so we call it a white zone. And so rapidly we understood that we were going to be one of the first medical deserts in France, and if we didn't take action, the healthcare offer for the population would be significantly reduced. So I heard Mr. Guy Valencien doing a conference on these maisons de santé. I felt that this was quite visionary at the time. And I was lucky enough to have an elected official, a local elected official, with whom we were able to work together And he and I launched this project. It was a long-term project. We didn't have any model. It wasn't easy. We wanted to have this pluriprofessional, pluridisciplinary center where the patient would be at the center. And so we had first-line care, second-line care. We had a preventive department. We had school medicine, occupational medicine, sports medicine, home care. And we even had the French health insurance agency that was present. And so we wanted to create also housing for medical students, something really complete that would be sustainable. And yes, I'm a rural GP, so it was a real change in my functions. It was a change in my outlook. And it's true that I wasn't prepared for this type of thing. I'm not a company manager. I'm not a legal specialist. I'm not an accountant. So yes, we had to deal with all of these aspects. And we had to have a whole series of meetings with all of the different players. When you start at the bottom, you go all the way to the top in the different political layers. So the local, county, the regional authorities, the different health insurance authorities, the hospitals. So it was open to everyone, so that there were private doctors working there and hospitals who also sent doctors, specialist doctors, and private clinics. So it was really open. So this required a lot of meetings. It took 4 years of just meetings, and now it's more formally organized. And so this is where the obstacles arise. It seems obvious, but it's true that France is such a layered bureaucracy, and so it's a hard system. And if you don't know the codes and the keys to the political system, in an administrative system in France, it's very hard to understand who does what, who gives what, who can finance what, who do you need to contact, what are the right offices. These are huge obstacles, considerably for a basic GP such as myself. And so sometimes you can be unlucky. You might be trying to do this during an electoral period. If it's an electoral period, this is what happened to us. You may go see these changes, administrative changes in the names of the regional agency. You can go and see the director, and then the new minister arrives in France and appoints a new director who doesn't have the same ideas as the previous director. So we experienced all of this. We accumulated all of this, and I had the impression sometimes that I was going to the same meetings over and over. I had the impression that I was kind of rowing against the current, and that was our biggest obstacle. But then there's also the fact that sometimes during these meetings, we could see people but who knew nothing about the medical sector, nothing whatsoever. Sometimes we had this feeling that they were just trying to come for show, and the politicians are there to show that they're doing something, but whether or not they reach results, it doesn't really matter. This was a feeling, a sensation that I had over the years. At the end, because we should say, I'm talking about the obstacles, but there are a lot of wonderful people who were involved along the way and a lot of devoted people who spend a lot of time. But the main obstacle that I encountered was this feeling that many people were not really trying to take into account the private doctor's life in terms of these meetings. These meetings, we have a continuity of health care, and people told us to come to a meeting at 3 o'clock in the afternoon. It's impossible. We had our patients. So if you say that you want the meeting at 8 p.m., it's difficult for the politicians to accept. So they're not used to working at those hours. So all of these things were complicated, but today the main obstacle is bureaucracy. All these forms to fill out, the different applications, the dossier. People say that there's a simplification underway in France. Well, sincerely, in the field, we haven't seen it yet. We haven't seen it at all, and it seems to us that it's even more complicated than in the past. So this means that today, if you're in charge of one of these maisons de santé, it's a full-time job, these healthcare centers. We need a coordinator to fill out all of the different therapeutic education applications where the rules of the game change all the time. So this is what really disturbed me the most, were these changes in the rules of the game over and over. Thank you. Thank you very much. Thank you, Didier.
Magnifique témoignage vécu et qui donne aujourd'hui lieu à...
This is a wonderful testimony of what can be done and what was done in the region of the Île-de-France. Antoine, MSP is a company. We are a company. You are a company. It's a central company. When you are in a primary care company, you are a key company. Now people try to organize us, but we will not lose our freedom of association and organizing ourselves between first-line care and second-line care. There's the issue of the blockades that we see. Over the last 30 years, we've witnessed wonderful things. Let's not forget about the blue skies, which is the extraordinary, the wonderful changes in our practices, in our tools. In terms of pathology, information means all this is new. We have never witnessed such changes. Now, we have to transform ourselves in that context, but we have the means to do it, and we have the means to do that transformation that everyone expects from us. There are wonderful speeches, great, that's one thing. But what about the reality in the field? And here there are two findings. First of all, our economic approach is schizophrenic. And it is all the more dangerous since today we have no visibility on prices. We are unable to say to all the actors and the stakeholders, staff members, we are not able to say on what path we are. Prices change every year. It's only on the yearly basis that I know what the rates are going to be. How can you plan in the long run when you don't have prices visibility, you don't have enough transparency about the rules? That's the first worrying aspect. Second worrying aspect, the explosive situation in social terms. We've had really sharp losses in wages. Our staff members have lost some 10% of their purchasing power. So there's no wonder that we're facing such a social tension. A year ago, I started to talk about it. We still live under the threat of social tensions. Thirdly, I came back to that profession some 10 years ago because I thought that we were losing sight of our priorities and purposes. We are here to have ambitious projects for our ambitious doctors. We have to stand behind a medical project, and this is about shared governance. Doctors have a project, and we have to implement it. That's our job. So let's put all the medical professionals at the very heart of our discussions. It's what I've tried to do over the last 10 years, and I more or less managed to do it. I think we are connected in the conquest of our territories, and the art of an entrepreneur is to find objective alliances between health professionals and company leaders. Thank you, Daniel, because you are giving some solutions after providing a diagnosis. very often people have said that patients have to be at the center of the health system, and Daniel Kai says that it's the doctor who has to be at the center of the health system. What do you think about that? Well, the patient is at the center because that's our job. We are here to take care of him. So fundamentally, the patient is at the center. It's the very meaning of our work. We have to be caring about our patient. But the organization of the team around the patient is major, and you have to remember that you have to enable medical professional teams to work with all the new means, digitalization, various means. We have to accompany our professionals, so we have to understand that the patient is at the center, but we are witnessing a personalization of the pathology of our patients. Now, we no longer deal with some illnesses, we deal with patients. That's quite new. It may seem abstract to you, but in real life now, what happens is that you have patients, they have illnesses, but the patients are at the center of our approach. Marc. Yes, I understand what you're saying, but there's a notion of meaning within our hospitals. There's a renewal of management, and we have to be able to base ourselves on the needs of patients. We need to have a bottom-up approach so as to enable our teams to be fully committed. Now we have rules coming from the top. We have various layers of standards, outside norms. There is an over-standardization within hospitals, and patients and carers don't know any longer what to do. They lose sight of the purpose of their mission. So we have to find a new freedom to enterprise, not in the economic sense, but in the medical sense. We need our practitioners to have some time and to be able to be committed within their teams. There are two changes which are fundamental and which are underway. First, hospitals, public hospitals, are considering the idea that care does not begin and end in the hospital. I've been working in public hospitals for 25 years, and up until recently, we considered that a deceased person was considered as a deceased person when he entered the door of the hospital. Now, this is being questioned. We are now considering that a deceased person becomes deceased at home, so it changes the role of the hospital within a wider chain. Secondly, a second revolution which is fundamental is the link between patient and practitioner. This is at the very heart of medicine, but health professionals have grasped, have fully mastered the idea that behind the patient and the GP, there are a number of people, engineers, biostatisticians, statisticians, funders, patient associations. It's not any longer an exclusive relation between the patient and the doctor. It's a relation within a more global environment. And what enables us to become aware of this is that we are entering the era of 4.0 hospital, a collaborative digital hospital in which innovation is a guarantee of equality of access to care. On a daily basis, we face many obstacles. We know many of them. You plan an appointment at a time when it's not possible. That's a very easy barrier to remove, but we have to see beyond and envisage wider perspectives within the framework of a collaborative hospital. Thank you, Aurélien. Aurélien. Yes, thank you. This is a very striking comment, and we hear that more and more often. It's all well and fine to have good intentions, but very often health professionals say to us, you are wonderful, you are imagining a new system, but the previous system has not been fully deployed yet. We hear that every now and then. So now we cannot require the health system to transform itself. We have to transform ourselves. My team is working on CPTS. It may seem striking, but in the Seine-et-Marne region, we have organized a public meeting with doctors at 8:30 p.m. Now we are talking about doctors who are not earning wonderful wages. Now we are convening a meeting at 8:30 p.m. That's not easy. Now, people talk about having a patient-centered system, and some talk about having a practitioner-centered system. Now, I think we have to get away from that discussion. The change will come from health professionals themselves. They'll say, we work in such and such a way. It's not technocracy. We work alongside the principle of equality, precautionary principle. But what is central is considering an entire project, and then we'll try to fit it in the existing spots. So whenever you have new projects, sometimes it will not work, but attempting new project has a value, and that value is superior to the price of any potential failure. We have a multi-layered system. We will not be able to reduce the number of layers, let's face it, but we have to cope with that multi-layer system. In the Paris region, we are trying to have one single file when people request support in order to enter the so-called maison de santé, the alternative health centers. We are trying to do that with CPTS. So we don't work separately between the ARS, the regional authorities, and the health insurances on the other hand. We try to deal with the complexity of the system and to have it work. This world is a transforming one, and our young professionals have different aspirations. We have to build on this and give them the means to work differently. So it will work only if all of us move together. We know that we can move along. We know that we should improve ourselves. We know that we should transform ourselves. We are now in the process of evaluating hospital directors in the Paris region. So they have a new objective, which is normally not their job. That is, the connection of the hospital with the surrounding city. That's new. That's an innovation. Directors can do this, but they're not used to do it. That's a new objective. So we have to take on this change collectively. So there are some positive aspects, although there are many negative aspects. Let's not deny the complexity of the situation, but let's also keep in mind the positive aspects. Thank you. Anne,
I'll just take this one off so that I don't hear myself. I absolutely follow you by the healthcare professionals. Often they have chosen their professions by heart and they want to do something meaningful. So we have, as managers, a very big responsibility to bridge the changes and the regulations, so that they see meaning in what to do. We were talking a little bit about patients before. I think we have a hidden resource in patients and relatives that we don't often see. In Denmark, we have stopped, not fully stopped, but sometimes we stop asking what matters to you. No, what's the matter with you? We don't ask. We ask what matters to you. And we can see that if you make co-decisions with the patients and relatives, what do you call it? The overall, no, I'll start another way. We can see that the, no, in I just lost it. Yeah, I could just speak French. I lost it. But I will see in our hospital, we are making a lot of changes. We're building a new hospital. That's very inspiring for the healthcare professionals. That's an open window for changes and innovation as well. We invite in the patients and we invite them to support us when we are building new ambulatories, for example. We invite them into the processes and we ask them, what matters to you here? How do we do this so that you have better pathways through the hospital? So I think that we mustn't forget the patient and the relatives. They could be a hidden resource for our hospitals.
Merci, Anne. Didier.
Oui, alors
thank you. Didier, in rural areas, it's difficult to determine whether it's the doctor or the patient which is at the center, because it's not the same question there. We still have family doctors in rural areas, and they are at the center of the system. When we created our Maison de Santé, we based ourselves on that notion, and our association worked together with a number of associations, including an association of users, and they provided their views and conveyed their expectations. Now, let's face it, the patient must not be the sole center. The patient also has to be educated. This is taboo somehow, but I think that we have to educate patients, and that should start at school. If you have a patient calling on Saturday or Sunday evening to the center of regulation, which is the number 3820, and he has someone replaying that he should stay at home, and then he decides to take his car and drive to the emergency ward for nothing, that's a problem. So patient education is central. Doctors must play their role, they must change the way they work, and they must work closer together with other healthcare professionals. This is what we do in the Maison de Santé, and this will be further developed in the future. But as you said, it takes a generation to totally change things. Now, regional health authorities provide some subsidies to the ambulatory care associations, so they have to better take into account paramedicals. At present, things are centered on patients and doctors. This is paradoxical because I don't think that it sticks to doctors' expectations. I think that what we really would need is a single window. So when you are lucky enough to have various health professionals working to work together and change things, when you are lucky enough to have in front of you a number of officials who want to change things, it should be simple. You should be able to make a file and to transmit it easily. It should be easy to sort things out without people saying to you, you should call this department or that department, that division. No, that's too complicated. We need simple approaches. Administrative burden is not our task. We need to have time to do our work. So, and we need also to be numerous enough. Please send us doctors in rural areas, and you'll see we will have great maisons de santé. Thank you.